Well, welcome if you've signed on to today's webinar. Hi, my name is Elizabeth Hargett, but you can call me Beth. I'm a physician assistant with Medical Group of the Carolinas. I'm located at the Mary Black campus in the Hugh R. Black Pavilion, and I've been working in orthopedic surgery now for approximately 4.5 years. And my heart and my passion has been for promoting good, healthy bone health. And so in the past 3 or so years, we have started a program within our orthopedic clinic that is really dedicated to identifying, treating, and managing osteoporosis. So that's what we're going to be talking about here today. If you guys have any questions throughout this, I want this to be interactive. Feel free to comment in the chat function below, and we'll get to those questions at the end of our presentation here today. So let's go ahead and dive right on in. So the first question we should all be asking is, what is osteoporosis? That's why we're here, right? So I have two pictures here, one on the right, one on the left, and you can see the one on the left has these big open holes in the bone versus the one on the right feels like a really tight-knit structure. So one on the right's kind of like a nice piece of bread, lots of dense material there, versus one on the left looks a little bit more like Swiss cheese with way more holes than cheese, right? So the World Health Organization, or WHO, defines osteoporosis as a disease characterized by low bone density, or that the bone is weak. And the problem with that is that weak bone is more likely to fracture or break if you were to fall or have an injury. So the question is, how does this even come to be? And it's really a question of bone metabolism. So whenever any of our body processes work, we have kind of a give and take, and that's true for our bones too. So we have some cells that's going to help build up our bone material. Those are like our construction workers of our bone or our skeleton. But we also have cells that's going to kind of eat away at our bones. So that's what that picture is there on the right. And that's normal, that's natural. We want to get rid of old bone, we want to move in new bone. But the problem is when we get out of balance. So that's where we end up with not enough builder cells and way more eater cells. And so it's kind of like having a net loss over time, where we just slowly start to lose bone material rather than having kind of keeping the status quo or having net gain. So let's talk about just how common this is, and it is pretty staggering when we start to look at the statistics. So we're looking at 10 million Americans, 200 million people worldwide have osteoporosis. It's responsible for approximately 2 million bone breaks every single year. And even though we know that bone breaks caused by this disease are happening, only about 20% of those patients that have a fracture due to their osteoporosis are being identified for osteoporosis and are being treated for their osteoporosis. So 80% of these patients that have these fractures are not getting or receiving treatment. And this is a major problem, especially when we start to look at hip fractures. So hip fractures are very common, around 300,000 every year, but the problem with them is not so much the initial healing, but the loss of mobility that occurs after sustaining a hip fracture. So we see that 25% of our patients will end up in a nursing home after sustaining a hip fracture, even if they weren't beforehand. And about 50% of them will have some loss of independence. So perhaps before they're walking independently, now they need the assistance of a cane, or perhaps before they were using a cane, now they need the assistance of a walker. And so we're seeing some loss of independence. And along with that, unfortunately, we're also seeing an increase in mortality rate the year following a hip fracture. So about 1 in 5 patients, or 20% of the time, our hip fracture patients will end up passing away the year after that they've sustained that hip fracture. And the thought is that it's less due to surgery and more due to the loss of independence. So, so there's definitely reason to think that this is serious. And like I said, it is very common. So we're always concerned about breast cancer and uterine cancer and ovarian cancer in women and prostate cancer in men, but osteoporosis is more common than all of those put together. So what does that actually look like for our community? It's about 1 in 2 women will end up suffering a fracture due to their osteoporosis, and 1 in 5 men. So men, you're not out of the picture either. About 20% of men will end up with osteoporosis and have a fracture due to it. This is another good slide. I really like this one because it gives a good visual for just how common this is. I think we all know somebody who's been affected by a heart attack or a stroke or breast cancer. We all have family members, maybe even ourselves, that have suffered with that. But we see that osteoporotic fractures are have a much higher incidence per year than any of those put together. And that's according to the National Institute of Health, the American Heart Association, and the American Cancer Association. So what can we prevent, right? So what are our risk factors? What plays into us getting osteoporosis? This is just a neat little acronym that helps us remember some of the big hitters. So one of the first ones here that you're going to see is alcohol use. So if there's ever been a history of heavy alcohol use, we know that alcohol can be associated with poor bone health. When you see corticosteroid use there, we're talking about prednisone primarily for longer than 3 months. A lot of our patients that have autoimmune disorders like lupus or rheumatoid arthritis might be taking 5 milligrams of prednisone every day for years to control that, but there is a risk associated with that when it comes to our bone health. Calcium is big. Your mother always told you to drink more milk when you were a kid, right? And that is true. We need our calcium to build good bones. So we're going to talk a little bit more about that, but one of the big hitters with that is our patients that have had gastric bypass surgery or not absorbing well in their stomach. We can see that they'll be low on the calcium, as well as people that are lactose intolerant or have just otherwise avoided foods that are high in calcium. Estrogen, we're going to talk more about estrogen too. But when we go through menopause, we can see a big dip in our bone health, and that's because estrogen is actually protective for our bones. And this is probably the most common is smoking. So we know that nicotine is associated with poor vascular supply, poor nutrient supply to our bones. And the heavier and the longer the use of the nicotine product, the worse our bone health will be. And then sedentary lifestyle. I like to think sometimes about bones like we would muscles. So the more you use it, the bigger it's going to get, right? But that's also true for bones. So if we're sitting on the couch all day, our bones aren't really being stimulated. So it's not telling our body that we need it. So that nutrients that's being held in our bones is getting sucked up for other uses rather than our body prioritizing our bone strength. So we actually want some impact on our bones. So our body's stimulated to keep that strong and big. Like I said, I'm going to hit a little bit more on menopause. This is why we see that osteoporosis is higher incidence in females than it is in males. And it's because females go through menopause. Men get to keep their testosterone a lot of the time, right? But not so for females. We know that typically around our 50s, we're going to go through menopause. That means that we're going to have a dip in our estrogen. And that's normal, right? That's good. But estrogen does help us kind of regulate our cells that eat away at our bones that we were talking about earlier. And so we can get out of balance where we have more cells eating away at our bones when we start to lose the protection of our estrogen. So we actually see about a 15% acceleration of bone loss for the first 5 years after menopause. So you can see that on that graph there. And this is especially important for my females that perhaps go through menopause early in life, around 35 or 40. That means that that decline is going to be going on earlier in life, which means that you're going to be at a lower bone density around your 60s than you would be for perhaps somebody who goes through menopause in their mid-50s. So definitely something to consider. And then we also have some medications that are going to play into our bone health as well. Now, that being said, a lot of these medications are really important for lots of other reasons. I don't like recommending patients to just stop taking a necessary medication. But at the same time, we also want to treat patients holistically, look at the patient as a full picture. So these are some things that can play into it. Some of them are modifiable, some of them maybe less so, but let's just talk about it really quick. So steroids was something I mentioned earlier. If you're taking it for longer than 3 months, your risk for osteoporosis does increase with that. Epilepsy medications. This is not necessarily all epilepsy medications, but particularly phenytoin, also known as Dilantin, is one of the older medications, been around for a really long time, but has a stronger risk factor for osteoporosis. Heparin is a blood thinner. We're really talking about getting blood supplied to the bone there. So a lot of times these very heavy hitter blood thinners can be associated with poor bone health. Immunosuppressants, we're just suppressing the bone there. Same with prednisone. Again, there's reasons to be on them, and so I'm not saying not to take them, only that is something to take into account. Lithium is a mood stabilizer that's often used for bipolar disorder and things like that. Some of our thyroid supplements, just because you're boosting the thyroid hormone, sometimes that can have an effect to our bone health as well. Chemotherapy medications, you got to have it if you're going through cancer, but yes, it's also going to be suppressive to the bones. And then heartburn medication is probably the most common one that I see. It's almost rare to see somebody in their 60s that isn't taking something for some heartburn, right? The reason that there's a connection there between heartburn medications and osteoporosis is actually because of how calcium is absorbed in our belly. So we actually want an acidic environment in our stomach for the calcium to be absorbed. So I'm not telling patients not to take their heartburn medication. What I am saying is to take your calcium supplement before you take your heartburn medication. And if you can actually take it with a little bit of orange juice, the citric acid in there will help you absorb that calcium and make it more useful. So you're actually getting the benefit out of that. So how do we know if we have osteoporosis? Are you going to feel different? And the reality is that no, this is a quote unquote silent disorder. That means you're not going to feel when your bones get thin. You're not necessarily going to feel when your bones get hard again either when we're treating you. So the only time you're going to feel that you have osteoporosis is when you actually have a bone break. And then you will absolutely feel that, right? Nobody wants to suffer having a broken bone. But that does mean that we might not feel any different. So if you've heard before, oh, well, I have osteopenia in my hip or in my back, that's not going to be the cause of your pain, typically speaking, okay? But when we're talking about fractures, some of the most common sites for fractures is in our spine, it's in our wrists, and it's in our hips. Now, those are just the most common. It doesn't mean that that's the full package deal, though, right? One in particular that we consider almost pathognomonic for osteoporosis, and pathognomonic means that it only really occurs due to having osteoporosis, and that's vertebral compression fractures. So essentially what that is that our back is made up of these nice little cube shapes, right? And say that there's some kind of stress on that back, and that cube shape wants to compress down into more of a little rectangle. So people can experience some shortening of their height. Maybe they lose a few inches of their height. They might hunch over, and they might have some chronic back pain associated with that as the muscles try to adjust to a new height fixture for them. So that's definitely a source of problem in osteoporosis, the chronic pain associated with vertebral compression fractures. And with that, we can also find, like we talked about earlier, depression, nursing home placement, and even fatality with those hip fractures. So what do we do, right? So we kind of know what it is. We know what the symptoms look like. Now what? So I recommend that all women over the age of 65 receive a screening test every 2 years. And that is in accordance to our U.S. Preventive Service Task Force. And it's a very easy process. I'll show you the picture here in just a minute. But men as well, I also recommend that they get screened at the age of 70 for this, okay? And we make some exceptions if perhaps you have some risk factors. So say we go back to that access screen and maybe there's some nicotine history or alcohol history. Maybe you've been on prednisone a long time. Maybe you have already suffered a fracture. Those risk factors might indicate to your provider that it's time to get screened a little bit earlier, maybe 5 years earlier or even 10 years earlier. But the classic time is going to be 65 for women and 70 for men. But risk factors, like I said, or a broken bone can indicate getting screened earlier. This is what a bone density test is going to look like. Sometimes we call it a DEXA scan, which is what you see there, the dual energy X-ray absorption meter, right? We just call it a DEXA scan or bone mineral density scan. But you can see this is not going to make you claustrophobic. For those of you that might be nervous about this is not a CT scan or an MRI. It's all very open. They're just taking a very vague picture of your hips and your back. It's less radiation considerably than even an X-ray. So very, very low radiation, just enough for us to see how dense that bone appears. So what's going to happen here is you can see in that picture we have our individual that's kind of running the test for us. So we're taking that vague picture, it's going through a computer system. That computer system is spitting out a number for us. And that number is going to correlate with how thick the bone is. So it's just an objective way to see how healthy our bones are. So we're going to take that number and we're going to throw it on a scale. Lots of disorders are more like a spectrum than a true black and white, right? And osteoporosis is really no exception there. So it's like a traffic light. We have a green side of the scale, and that's all of our good normal bone. That's going to be positive numbers primarily, all the way down to -1. And then we have our yellow zone. Now, the yellow zone is what we call osteopenia. Osteo meaning bone, penia meaning less than. So a little bit less bone. And then our red zone, our big traffic light red, right, that's our osteoporosis. Osteo meaning bone, porosis meaning more pores. So more of that Swiss cheese appearance to the bones, okay? That's anything more negative than -2.5. So if you're looking at home at your My chart, that's the number that you're looking at, okay? Now, one last thing on this slide, though. This is an objective way to look at the density of the bones. However, it's not necessarily going to tell me your quality of bone. Okay, so quantity and quality are two separate things, right? So say that you've had some compression fractures, or maybe you have some really bad arthritis. Sometimes that can fool our bone density scan, and it can make it look thicker than it really is. Just because there's more bone material doesn't mean that that's structural supportive bone material. So just something to be considering. I know your providers are thinking about it. I'm thinking about it. Something for you to also think about when you read your bone density test. If you have had multiple fractures and that bone density test looks normal, maybe the bone density test is being fooled. So we always want to take the patient, you, into account more so than just the numbers, okay? So let's talk about our risk factors, the things that we're going to start doing at this point. So first thing to start with always is kind of our building blocks when it comes to our bones. So calcium and vitamin D. For an individual that is perhaps over the age of 50, right, we really want them to be taking in somewhere around 1,200 milligrams of calcium every day. So that would equivalent to about 4 glasses, tall glasses of milk a day. I don't know about you guys, but most of us are not drinking 4 tall glasses of milk a day, right? So we need to be looking at something else. Perhaps if you're lactose intolerant, almond milk actually has more calcium in it than dairy milk does. So be reading the back of these cartons and stuff too when you start looking for alternatives. So almonds alone, if you just like snacking on nuts, those are high in calcium. You can also, of course, be looking at yogurt and cheese. Some of our green leafy vegetables like broccoli and kale are also high in calcium. And then sardines and salmon and beans. You can also Google some more too if you're looking for some more dietary sources. I always recommend increasing your dietary supply of calcium first. You're going to absorb that better than a pill. That being said, if you're not getting it in your diet, it's not going to hurt to take a calcium supplement just to kind of fill in the gaps there, okay? And then when we're looking at vitamin D, the base, like lowest that I want one of my patients, perhaps over the age of 50, to be taking, excuse me, is about 1,000 units of vitamin D a day. And you're going to see on the counter there's D2, there's D3. What should you take? When you're looking at increasing your vitamin D levels, the D2 is going to kind of spike you up back towards normal range a little bit faster, and then it's not going to provide a lot for you long term. And D3 is going to kind of help you maintain and have some gradual progression in your bone health over time. So I typically recommend D3 long term, and D2 short term. So if you're looking over the counter, you're seeing 1,000 options. It's like looking at toothpaste. I know there's tons of stuff out there, but that's the advice I would recommend there on vitamin D. And then, of course, going back to that access picture that we had before, quitting nicotine is going to make a huge impact on your bone health. So if you're smoking at all, something to absolutely keep in mind. There's lots of reasons to quit smoking. This is just one of them. Reducing your alcohol consumption. Like I said, bones are kind of like muscles, right? We don't want to be too sedentary. So get up, get moving. This is probably the one time in my orthopedic career that I don't always recommend getting in the pool, where we don't put weight on our bones, because we actually want some impact on those bones. We want the bones to wake up. And then, of course, when we're looking at fall risk prevention, which we're going to get into a little bit more here in just a minute, but muscle strengthening, resistance exercises is going to improve our balance, improve our agility, and help maintain bone strength. Like I said, our fall prevention plan here, excuse me, we're not going to go into too much detail on this, but I just wanted to put it out here. You can find this online if you want to go back and review it in a little bit more depth. But it's simple things, standing on one foot every day for about 30 seconds, just making sure that your balance is there. I do recommend holding on to something for my patients here when you're practicing, okay? Making sure that your medications are being checked by your primary care doctor, that there isn't too much in there that's going to make you dizzy or increase your risk for falling at home. Making sure you have good vision support, that you're able to see well, that you're not struggling too much with cataracts or poor vision. And then, of course, putting safety features in place at your home, night lights, handrails, making sure there aren't wires or rugs that you can trip over. All these things are important. So this is our Stepping Out Strong program here. Again, you can look this up online, but it's just ways that you can be increasing your leg strength, because we don't want to fall, and keeping mobility. And here's just some more pictures. And like I said, feel free to look this up online. Again, it's called Stepping Out Strong. And then to accompany that, we also have a program called Too Fit to Fall, or Too Fit to Fracture. Same kind of thing. It's all about strengthening and core strength and balance. These are also very safe exercises for my patients that have vertebral compression fractures. We don't want to do a lot of heavy bending, and we're going to get into that a little bit here. I think I have a picture on that as well. But when you have vertebral compression fractures, we want to be careful about the stress that we put on our back. So making sure when you're looking at balancing programs that it's something that's going to be safe for your back is very important. And this is true for all Americans, but also particularly for my osteoporosis patients. You want approximately 150 minutes per week of some cardio activity. So aerobic activity, brisk walking, dancing, jogging, silver sneaker classes are great, things like that. Get a community around you, get some support, and that's going to really help your bone health. Okay, here we are, our spine sparing strategies, okay? So this means modifying some of our activities, the things that we know we're going to bend over for, like getting our sneakers on or picking up something from the ground. Maybe we want to get one of those gripper devices so we're not having to bend over for the dog toy. Making sure that when we do bend over, we're bending with our knees, not our back. And if we're going to kind of twist, we don't want to do that with our back, right? We want to take a step out and then turn rather than put that stress on our back, especially right after having a spine fracture. So say that we've done all the risk factor modifications, we've done everything that we can, and we still have osteoporosis. And this is a lot of my patient base, right? Sometimes the conservative stuff just isn't enough to really get our numbers back into the normal range. So here's some medication options. And of course, you want to talk to your provider in person, really go through what's the best option for you. So I'm just going to lay out some basics here so you can be familiar when you do have that conversation with your doctor. One of the major first classes of medication when it comes to our bone health is called bisphosphonates. So we have the pill form of bisphosphonates, we have IV form of bisphosphonates. You probably recognize the name Fosamax or allodratinate. It's one of the medications that was really first on the market. There's tons and tons of research for many years on this medication. You might hear about a friend who's taking a pill once a week, and it's probably that one. The struggle with oral bisphosphonates is that it can sometimes worsen acid reflux. So you're going to hear instructions like, don't lay down after you take it on an empty stomach. You want to be upright for approximately 30 minutes, and then you can take everything else. So a few rules with the pills, but pills are easily accessible, and it's a good first starting step. You might hear of a friend who's maybe just getting an IV infusion once a year. That's probably reclass that you're hearing about. That's a medication that you can take for 3 years. And the oral bisphosphonates also have some deadlines on them too. So it might be 5 years, it might be 10 years, depending on which pill that you're going with. But something to consider with bisphosphonates is that you kind of need a bisphosphonate holiday. Now, I say holiday because I don't mean retirement. We still have to check your bone health. We still have to be on top of it because although we are treating our osteoporosis, it's really more like managing. There's not a great cure out there for osteoporosis. It's not like we're going to do something and you're never going to have problems with osteoporosis again. We're going to have to continue to watch your bone metabolism to make sure you don't fall back into having thin bone again and putting yourself at risk for another bone break. So something to consider with these medications is holiday periods, treatment periods, and perhaps kidney issues and stomach issues, okay? Denosumab is often called Prolia. You may have seen the commercials for it or the pamphlets for it. It's got like the picture of a woman walking down the stairs and tripping on a dog toy or something like that. This medication has been out on the market for a good while now and has a lot of good data behind it. It is considered more effective than the bisphosphonate therapy. The nice thing about this is that there's no harm to continuing to take it for as long as it provides you benefit. So we don't have to worry too much about holidays with this one. You're not going to be at increased risk for side effects if you continue taking it, which is really nice when we're looking at prescribing. It's just an injection that you're going to get in your upper arm about twice a year, so every 6 months, and it's working on the cells that eat away at your bones. So it's kind of correcting the balance from that side of it. The other nice thing about this medication is that it's really kind of plays well with everything. We can bypass the GI system. You could take it if you're on dialysis. If your kidneys were really bad, you could still take this medication. Even if you were on chemotherapy, you could take this medication. Really plays well with the body. No real major medication interactions. So it's a nice, easy choice. And then say that you have had a fracture in your back and you're currently trying to heal that fracture. One of the best medications on the market are these what we call anabolic agents, which really just means that they're the only medications on the side of the scale that's going to actively build the bone. So it's going to be working on those construction workers, on boosting the cells that build bone. So you can take this while you're actively healing a fracture. And you can especially take it if you have any spine complications. Perhaps you're preparing for spine surgery and you want to make sure that your bones are really healthy enough to undergo surgery for your spine. The names for these are Tymlos and Forteo. If your doctor starts talking to you about them, it is a daily injection, and that's usually where I lose patients on this medication, is that it's a little bit more involved, but there's a light at the end of the tunnel. This isn't diabetes. You don't have to do it for forever. It's really just 2 years. And even if you just use 6 months, there's still some benefit just to getting going on a medication that's going to wake up the cells that build up your bone. Okay, so that's that medication. And then here's just my references. So if you guys have any questions, this would be the time. Oh, good. We have some questions. Wonderful. Okay. So I'll read these out for you guys. It looks like our first question says, I had hip replacement around 10 years ago, and I'm starting to have some groin pain. Okay. Does that mean my replacement might be degrading the surrounding bones? Not necessarily. I would recommend getting an x-ray to see how that prosthetic looks, to make sure everything looks right. I would also still recommend getting a bone density test, right, and just seeing how thick and healthy the bone is. Sometimes it can be muscular, sometimes it can be the prosthetic has a problem with it. But definitely something that I would say, please do talk to your orthopedic surgeon about that and get some x-rays. Okay. And then my next question is, are bone screenings covered by insurance? I'm scheduled by own. Oh, you scheduled your own bone screening, or do you need a physician referral? Okay, great question. Yes, if you get it at 2-year intervals and you have risk factors, you have reason to get a bone density test screening, your insurance should cover it. I say should because I don't know everybody's plan. But yes, you probably want to talk to your primary care doctor and get a physician referral. I'm not aware of patients being able to schedule their own bone density scans, but just because I'm not aware of it doesn't mean that it's not doable. Only that I'm just used to ordering it for my patients. So I would probably go through your primary care doctor. That way it's in their system too, and your primary care doctor can see all that information, and all the doctors that are working on your bone health or are working on your health overall are aware of where you are on that. Is osteoporosis genetic? And yes, there is a family component to osteoporosis. So something I always ask my patients is, do you have a family history of hip fractures? So did your mother have a hip fracture, your sister or aunt? Maybe your grandparents had hip fractures. There is an increased risk of that. And actually, we most use our bone density test screening that we talked about, the DEXA scan. There's also another screening test called the FRAX score, and that does actually include family history in it, and it takes a little bit more of a clinical picture. So yes, there is a genetic component to osteoporosis. So great question. All right. Well, if you guys want to contact us, you want to get involved, you want to get seen, there will be a follow-up email being sent out with a link and a copy of this presentation, so you can rewatch it. You can send it to family if you want to, and it'll also have some contact information in there, okay? Thank you guys so much for participating and logging on today. I really appreciate it.